much air in the tire, eventually it's going to blow. Okay, it's called barotrauma. We don't want to do that. So, who do we not put this on? Well, we don't put this on patients when they're unconscious. Are they going to be breathing on their own? Typically not. Unable to cooperate. If you have a patient that will not accept that mask, do not try to put it on their face. Okay? Hypotensive. If their blood pressure is below 90, what did we say? It's going to decrease preload and afterload, so it's automatically going to lower the blood pressure. You don't want to decrease the blood pressure of somebody who's already got decreased blood pressure, because then they're going to have no blood pressure. Okay? Another bad grammar, just throw it. If they're vomiting, why? Aspiration. Because then you're going to blow chunks, literally, into their airway. If they have a pneumothorax, so if they have a collapsed lung, do you want to further collapse that collapsed lung? No. Or do more damage to it. If they have chest trauma, you don't want to do it. Or facial trauma. Because guess what? You're going to blow the broken teeth that are in their mouth back into the airway. If they have any sort of facial abnormality, again, facial trauma. Or they have a face that will not form a good seal. Because then you're not doing anything. If they can't form a mask seal, you don't want to do it. And if they have pulmonary fibrosis or cystic fibrosis, you don't want to do it because that lung tissue is very, very delicate. Okay? Then it says, extreme caution, don't use it. So pay attention. If it doesn't look like it's working or it looks like it's causing more problem than good, stop. Seems like an easy idea, right? How do we do it? Every system's a little bit different, but it's literally a mask. No different than your normal breather. Okay? And all we want to do is create gas exchange. So, what I'm going to do now is I'm actually going to show you, and we're going to put them on capnography, because that's going to tell us if everything is working. That's my go-to. Capnography on everything. You know, I feel like Oprah on, Christmas. You know, everybody's getting cars. All right? You want to coach them. This is the most important thing. You got to talk to them. Anything you do to your patient, you want to talk them through. Because if you don't, and you just slap a mask on their face, they literally are going to they already feel like they're suffocating. If drowning is nothing but suffocation with fluid involved. Okay? If you're in CHF, that's literally how you feel. So you're already in like stage 3 of 5 when it comes to mentation. You're already freaking out. You've gone through normal, anxious, agitated. You might be agitated or altered. And trust me, an altered patient who can't breathe is not a fun patient to deal with. Okay? So reassess lung sounds. Because you want to see, is there still fluid in those lungs? Are the lungs open? Do I hear that whoosh of air that I'm supposed to feel? Or hear? Okay? You can use an inline nebulizer. But remember, you can't use the inline nebulizer and CPAP, and capnography for long because it'll clog your tube. Your neck tube. Nitro can be given momentarily by lifting the mask. All you gotta do is lift the mask, put it underneath the tongue, make sure it's underneath the tongue, because if they swallow it, they're gonna vomit. It's gonna be awesome. Alright? If the patient gets worse, go to advanced airway. They might have to get a tube. Okay? Call for ALS. CPAP can cause a drop in blood pressure, so if you see blood pressure dropping, pay attention to it. If it goes below 90, you may have to take them off. Watch for gastric distension. That can lead to vomiting. And the patient may become claustrophobic or unwilling to tolerate the mask. Okay, so you're going to have to talk to them. That's the most important thing. Talk to them, talk to them, talk to them. Okay? Don't use on children under 12, but actually this is changed to children under 8. And in certain instances, we can use it all the way down to the age of 5. And please God, if you have a patient on CPAP, you better call the hospital as soon as possible and tell them. Because when they get to the hospital, they're going to need to know that they have to have respiratory there to put them on another CPAP. Because your oxygen bottle ain't going to last that long. Okay? Alright. So, the easiest way to think about this, and this is more advanced, but if you have pulmonary edema, CPAP is pulmonary edema or fluid in the lungs, like D50 is to people that have hypoglycemia. If you've got pulmonary edema, you're getting CPAP. If you've got hypoglycemia, you're getting D50 in the vein. It just is what it is. Okay? You want to make sure that they have bilateral chest wall movement, and you want to look, listen, and feel for that lung movement. Okay? Or that chest wall movement. Okay? We're using this in respiratory distress. We're definitely using this in respiratory failure. And the way you know the difference is respiratory distress is you're maintaining to some degree normal O2 and CO2, but you're having a little bit more effort. Respiratory failure is you're not keeping up with anything. You've got low O2 stat, your CO2 is high, you know, what have you. Okay? So respiratory failure, we're leaning more towards CPAP and intubation. Respiratory distress, we may be leaning towards bagging at that point, but we're trying to keep them from here. Okay? Trying to keep them from failure. All right? Respiratory distress, they're going to be tachypnic, which means that they're what? What does tachy mean? Fast. Fast breathing, tachycardia, fast heart rate, accessory muscle use. Do you see a fat dude that you can see his ribs? If you see that, you got a problem. Okay? Decreased tidal volume, which means increased respiratory rate, right? Tachypnea, decreased tidal volume, to try to maintain that same amount of air going in and out of the lungs every minute. And then paradoxical abdominal motion, seesaw breathing. Belly moves, chest moves. Belly moves, chest moves. That's not supposed to happen. Respiratory failure. Remember we talked about that level of consciousness change. Now they're becoming altered and then unresponsive. CO2 is going to climb and they're going to become respiratorily acidotic. So that pH is going to be low. CO2 is high, pH is low, that's respiratory acidosis. Okay? In a nutshell. Okay? So in summary, we're going to use beta-2 agonists. So all that is like your albuterol. We're going to put them on CPAP for CHF. All right? And it's definitely less invasive, keeps them from getting infections. That's what we want at the end of the day, is keep these people off the ventilator. That's all our end goal is, okay? That's all our end goal is. Give me just a second. Sit. We're going to go to the YouTube. Okay. I can spell that again. Okay, we're going to see a very interesting video here. Whenever it's that stuff. Take a look at these lungs. These lungs are completely deflated. They're not bagging or anything.
That we would use it for.
So this is what CPAP or PEEP specifically will do for your lungs. You see how they've expanded a little bit, and with every breath they're expanding a little more, but they collapse completely back down.
So our pressure is at 30 centimeters of water pressure, and then we currently have a PEEP set at 3, which would be fine depending on what diagnosis that your patient has, but for those patients who need a lot of PEEP, somebody who has refractory hypoxemia, or somebody who has ARDS, we have to use a lot of PEEP, and so we end up increasing that PEEP in order to increase the oxygenation, which works really well for alveolar recruitment and rebound or refractory hypoxemia. But we work so hard, and you can see us increase the PEEP, how much more inflated the lungs become and end up staying because we keep that baseline at a higher level. And so we'll just keep increasing the PEEP. I've got it up to 8 now. And I'm going to add in here for the nursing students, we're not as savvy with ventilator lingo and what things like PEEP are, but if you'll know, what PEEP basically is the pressure that the ventilator is going to leave in the lungs, so we don't have alveolar collapse and lose all of that headway that we've made with mechanical ventilation. So basically, in a nutshell, that's what PEEP helps us to do. If you zoom up right here, you can see some of this area that's been collapsed.
Now you see the difference that the alveoli are completely expanding? And see how much more pink those lungs are now? They were really red at first, but now they're more pink, which tells you that they're oxygen rich right now. And you see how they're just staying open.
Oxygen to the blood
That's
to be
what you
carried
want.
to the rest of the body. So you can notice that there's a whole lot more air basically left in these lungs after each inspiration as there was when we first began, because we've increased from a PEEP of 3 to a PEEP of 8. So this is exactly what we want. We want all those air sides to be working together, but then we've gotten the patient where we want them to be, and we've gotten the oxygenation up, but now we need to break that ventilator circuit to either give some medication or to change the ventilator circuit. And then what happens is we get this huge de-recruitment of alveoli in just a couple breaths, just long enough to unhook that circuit. And it takes a few breaths just to get back up to where we were, let alone any kind of therapeutic use.
So, there's that one, and I got one more. Got one more I want to show you.
You're recording again. This is a
Now
different
again, this
angle.
one shows it a little better.
And on
These are
shots.
rat lungs.
And we're going to go to 15.
See how they completely collapse every time you breathe? This is actually what our lungs do. With just a small amount of pressure to keep them open. Look how much more of the alveoli you're actually using. Look at the color change in those lungs with every breath.
And back to zero.
And now they went back to zero. That was only 5 centimeters of peak. That's not a lot. But it shows you just how little, as they said, little dab will do you. That's all it was. Small amount makes a
You
huge
can
difference.
see some of the portions.
The alveoli are trying to open, but it's just not enough
Like
force.
inspiration.
But the minute we put a little peak behind it, those things open up, oxygenation is happening, and ultimately, perfusion is happening. Okay. That's it. Okay. All right, so what we're going to do is we're going to head into the laboratory, and we are going to discuss